Okay, I'd like to welcome everyone to our regular scientific meeting of Cairo University Plastic Surgery Department. We're happy to have you tonight with us again. Tonight we'll be having our talk regarding the VPI and its management, presented to us by our professor, Dr. Ahmed Hashim. Dr. Khalid Makin, head of our department, will just give us a word to begin with.
Thank you, Ahmed, for this presentation, and I welcome everyone to our scientific meeting, the regular scientific meeting of our department, Al-Asr Al-Aini. And I really appreciate this group of meetings about the cleft lip, cleft palate, and today with the velopharyngeal dysfunction. I'm thankful to Dr. Mamdouh Abu Hassan, Dr. Ahmed Hashim, Dr. Dawlat Amara, and all our team for this very hot scientific topic, and I welcome everyone. Go ahead, Ahmed, now we can start. Thank you.
Okay. Is my screen shared? Can you see it?
Not yet, I'm waiting for sharing.
Okay. So really, velopharyngeal dysfunction is quite a critical topic for those who are involved in the management and care of the cleft patients. I think this topic, especially for the residents and young plastic surgeons, is critical to really understand why we are doing the cleft palate repair in the first place. I'll try to sum up this topic in a short presentation. So really the idea behind cleft palate repair is really, and the most important aspect and the most important motive why we are repairing the cleft palate is for having an optimum speech for these kids. So speech is a combination of words, and these words are formed of phonemes, and these phonemes are but vowels or consonants. Vowels are sounds produced within open vocal tract, where the tongue does not touch the lips, the teeth, the roof of the mouth, or any of the other articulating organs. Consonants are sounds articulated with complete or partial closure of the vocal tract. Normal human speech is produced with pressure from the lungs, which creates phonation in the glottis, in the larynx. And this is then modified in the distal vocal tract into the different vowels and consonants. So the air is exhaled under pressure through the larynx, and this causes vibrations of the vocal folds, and this produces the sounds. These sounds are then modified in the distal vocal tract by the different organs of speech articulation, which are the tongue, the lips, the teeth, the roof of the mouth, to produce the different letters which form the words. So what's the velopharyngeal mechanism, and what is its role in the in speech? The main function of the velopharyngeal mechanism, or the velopharyngeal port, is to uncouple the oral and nasal cavities during speech production. So if you take a look at this lateral ceph, in quiet breathing, the velum or the soft palate is hanging, while when you start speaking, there is upward and backward elevation of the soft palate, the velum, towards the posterior pharyngeal wall, closing the oral and nasal layer. This happens especially during consonant production. This is a real-time MRI just to show you the function. You can clearly see how the soft palate is elevated upwards and backwards to towards the posterior pharyngeal wall to close this port. So what happens when this port is dysfunctional? You can have hypernasality, nasal air emission, imprecise consonants, and these lead to compensatory articulations. So by hypernasality, what we mean by hypernasality is excessive nasal tone when you pronounce the vowels, the I, the E, the U, and the O. Nasal air emission is the escape of air during consonant production. Remember that normally when you spell the consonants, the T, the P, the S, the sh sounds, these sounds, there shouldn't be any nasal tone to them. There shouldn't be any nasal air escape during production of these sounds. This nasal air emission can be audible, and it's called then nasal turbulence or inaudible, and then you can detect it either with a stethoscope or with a mirror placed under the nares, or even with a straw. So when you have the imprecise consonants because of the nasal air escape, there is failure to build up enough oral pressure for these consonants to be spelled correctly. And then the patient will develop compensatory errors of articulation. The simplest that you really will let you understand how that works is the word glottal stops. So in glottal stops, instead of saying glottal, you would say glottal. So the sound comes from actually from the larynx, from the glottis, rather than the T sound that we usually use. So an intact velopharyngeal mechanism is absolutely critical for normal speech production. So, and for this reason, the cleft palate repair is probably, I would say, one of the most important steps, milestones for these babies who are born with a cleft palate, because if they do not develop normal speech, they will not be understood by their peers in the kindergarten or in the early school years. They will not be able to make friendships. They will be socially in an unfavorable situation. The teacher will not understand them. They will be labeled as mentally subnormal because of that. And their potentials, just from a social and career standpoint, is much compromised because of this. So for this reason, the palate repair, the primary cleft palate repair, is absolutely critical and important for these kids, and should be done really with the utmost care. There are so many muscles involved in the fine-tuning of the velopharyngeal port. Probably the most important of them is the levator veli palatini muscle. It arises from the petrous part of the temporal bone to be inserted into the palatal aponeurosis, and this is a sagittal cadaveric dissection showing this muscle. Together with the contralateral muscle, it forms the levator sling, which pulls the palate upwards and backwards towards the posterior pharyngeal wall. In cleft palate patients, it's not only the issue of free oronasal communication because of the anatomic defect that is present, but also the abnormal insertion creates abnormal dynamics of myoneural dynamics of function. And for this reason, the muscle repair or the myoplasty, that is an integral part of the palatal repair, is very important. The other muscle is the superior constrictor. This arises from the base of the skull and the median raphe of the pharynx, and is inserted into the medial pterygoid plate and the pterygomandibular raphe, and it forms the posterior and lateral walls of the pharynx at the level of the soft palate. Its function is to contract during and really receive the receding velum during contraction of the levator. So it is an important contributor to the velopharyngeal port. The other two muscles, the palatoglossus and the palatopharyngeus, both of them form the anterior and posterior pillars of the tonsils. They are actually depressors of the soft palate, and are actually antagonistic to the function of the levator. They are believed to be responsible for the fine-tuning of the velar motion. In speech, the sounds and the movements produced are voluntary movements that are learned and controlled by the motor cortex. In contrast, similar movements that happen during swallowing are involuntary and controlled by the brainstem. From a physiologic standpoint, there are different patterns of velopharyngeal port closure. It can be coronal, sagittal, circular with a passivans ridge. The most common in most healthy individuals is a coronal pattern, and also in most of the velopharyngeal dysfunction patients. The position of the velum, the soft palate, in relation to the posterior pharyngeal wall at any point in time is actually the net result of a complex interaction between different variables that involve auditory and proprioceptive feedback. From a pathologic standpoint, we can differentiate velopharyngeal dysfunction. This dysfunction can be an insufficiency, which is a structural anatomic defect, and the commonest example is the cleft palate patients. Or it can be an incompetence, where you have the anatomy intact, but there is a functional element that inhibits the muscle activity. And an example for that would be patients with cerebrovascular incidents. There can be velopharyngeal mislearning, which can happen if one of the phonemes is mislearned. It can happen with hearing loss, or it can be combined, like in 22q11.2 deletion syndrome, the velocardiofacial syndrome, or you have a submucous cleft and at the same time neuromuscular hypotonia. The diagnosis is best in a multidisciplinary cleft team, and really the issue of the speech and the outcome of the palatal surgery underscores and highlights the importance of the team approach that has been emphasized by previous speakers like Dr. Dawlat and Dr. Mamdouh. It's absolutely critical to care for these patients within a cleft team, and the speech pathologist is an integral part of that team. The diagnosis is based on history and clinical exam, perceptual speech evaluation, instrumental assessment, imaging, followed by team discussion. And we will talk about each of these items. I will not go much into the details of the history and clinical exam, but just a couple of points. So the history of cardiac defects, neuromuscular disorders, swallowing difficulties, ear infections, previous surgical history. These are very important aspects of the history. During examination, it's important to look for the craniofacial symmetry, the orofacial symmetry during speech, dentition and occlusion, the condition of the tonsils, if they are enlarged, the symmetry thereof, and then the looking for the presence of any evidence of a submucous cleft, like zona pellucida, bifidovilla, the posterior nasal spine being replaced by a notch. In addition, looking for the motion of the velum, the soft palate, and its symmetry is also important. The perceptual speech evaluation is the gold standard, and by that we mean the assessment of the speech pathologist of the speech samples obtained by the patient. So usually they would comment on the intelligibility, the resonance, the voice, and the articulation within a spontaneous speech sample, picture description task, or sentence description tests. And they will talk about the intelligibility, which is the number of understood words within the speech. Resonance, and by resonance we mean the the relationship of the nasal versus the oral energy during speech. And you can differentiate the presence of hypernasality, which means there is excess nasal energy to the speech sounds, especially the vowels, or versus hyponasality. And hyponasality is you can very much appreciate it in the M and N sounds. When they sound, these sounds are usually nasal. When they sound less nasal than they should be, they describe hyponasality, which signifies a form of obstruction at the level of the nasal cavities. Or it can be mixed. The air can be trapped. Excess air can be trapped within the nasal cavity, but then there is an obstruction like a septal deviation. Nasal emission and turbulence. Nasal emission describes the escape of air through the nares during consonant production. If it is audible, it's called turbulence, nasal turbulence. And then comment on the compensatory articulation errors that exist in the particular patient. This paper from the Journal of Pediatric Otolaryngology is published from the Mansoura University, and it is a very nice characterization of the articulation errors in Egyptian Arabic-speaking children with cleft palate. It's an important reference for us. So the instrumental assessment, these instruments, so the speech pathologist can use certain instruments to help him solidify his impressions from the perceptual speech assessment. So they can use nasometry, which is the picture in the upper part of the slide. This is a headgear that on which is mounted a microphone to the nose and microphone to the oral to the mouth, and the child or the patient has to repeat certain sentences, and the system analyzes the amount of energy, sound energy that is produced from the nose and from the oral cavity. Commonly, they describe what's called nasalance, which is a ratio between the amount of nasal energy, nasal sound energy, in relation to the sum of the nasal and oral sound energy produced. And this gives an indication of the amount of hypernasality present. The other instrumental assessment is pressure flow testing, and this is an aerodynamic study where pressure transducers are connected to the nares and to the oral aperture, and it analyzes the flow and pressure from these organs. So these equipments are costly. They obviously require a cooperative patient. So imaging is extremely beneficial when you are moving towards planning of treatment. The basic imaging modality is the static lateral ceph. The static lateral ceph can give an overview of the length of the velum, the depth of the pharynx. And when you do these static lateral ceph, they are produced during quiet breathing and during sustained sound production. So they can give a sort of indication as to the function, but they can't give a three-dimensional assessment of the defect of the velopharyngeal port and its true functionality.
Dr.
And for
Ahmed,
that,
can I have a question, please?
yes, please.
So the previous methods or techniques being used in the slide before imaging, so they're mainly used to diagnose VPI, or do they help as well in planning for surgery? These devices. Yes.
Yeah, nasometry, I have seen nasometry. I have not seen pressure flow testing. It's an adjunct to the perceptual speech evaluation to really solidify the diagnosis. So in patients, when you have patients borderline and you want really to assess the degree of nasality and make comparisons and make research, they are important for that. As regards the decision to move on to treatment, I think most centers nowadays would rely on perceptual speech evaluation in addition to nasoendoscopy, which I will be talking about in a minute. So video fluoroscopy is actually barium is instilled through the nose, and by doing that, it defines the surface of the soft palate and the posterior pharyngeal wall, and then you can get a sort of real-time capture of the function. So you can see in the image, the video on the left side. This is a patient who has adequate velopharyngeal function. The soft palate opposes to the posterior pharyngeal wall in a satisfactory fashion. While in the video on the right side, you can see that the velum falls short of meeting the posterior pharyngeal wall, and the velopharyngeal there is a velopharyngeal incompetence. And by obtaining multi-view assessment, you can get an idea about the three-dimension of the defect that is present. The problem with the video fluoroscopy, it's a high radiation dose, and I think many centers have moved away from multi-view video fluoroscopy because of that, and because of the better quality of images and assessment obtained by nasoendoscopy. So nasoendoscopy is an endoscope. It's a thin fiber optic endoscope that is introduced through the nose. And when you do that, you get a real-time capture of the function of the soft palate as well as the posterior and lateral pharyngeal wall. And the video on the left side shows a patient with adequate function. The velum and the posterior and lateral pharyngeal wall all function together to in harmony to get adequate closure of the velopharyngeal port. While on the right side image, you can appreciate that there is failure of the velum to reach the posterior pharyngeal wall, with deficiency on the function of the posterior pharyngeal wall. So the beauty, you can have a clear idea about the defect and exactly where it is, and it gives you an understanding about the planning that you need, the type of surgery, if any, is required that you need to do. Real-time MRI is still an investigational tool under study in these cases. So I urge you all to look at this paper, CME article by Hopper et al. It's quite informative, and for the beginner would serve really as a nice platform to start from understanding this fascinating topic. So treatment requires a multidisciplinary approach. The input from the speech pathologist is extremely important. The goals of treatment is to achieve competence in the velopharyngeal mechanism with the least morbidity to the nasal airway. The most common treatments that are available for the surgeon is either the Furlow double opposing Z-plasty, the posterior pharyngeal flap, the sphincter pharyngoplasty, as well as posterior pharyngeal wall augmentation. Prior to surgery, it's absolutely critical to assess for the presence of obstructive sleep apnea, to assess the condition of the tonsils and adenoids. And many centers would routinely perform tonsillectomy and adenoidectomy for these patients like 6 months prior to velopharyngeal surgery. And the reason for that is that over time, if you leave these lymphatic organs, they will undergo atrophy. And then whatever type of surgery you have done, this will change because the cross-sectional area of the velopharyngeal port will eventually change when these tissues atrophy. If there's any residual palatal fistula of significant dimension, it should be repaired before embarking on performing of velopharyngeal surgery. And also previous velopharyngeal dysfunction surgery is important to be assessed. In general, the operative decision is dependent upon the relationship between the length of the limb in relation to the depth of the pharynx and the lateral pharyngeal wall. In a short velum with good lateral wall motion, the most appropriate would be a posterior pharyngeal flap. If you have a soft palate of average length and elevation, but diminished lateral wall motion, then a sphincter would be the answer. However, these are not strict rules, and surgeon preference. Concerns with the airway and previous velopharyngeal surgery are all factors that can alter the eventual and final decision. The Furlow double opposing Z-plasty, by its geometric design and unique ability to reconstruct the levator sling, has been effective has been proven to be effective in studies in small gaps less than or equal to 5 millimeters, and even 8 millimeters in some studies. They are very beneficial in cases of submucous cleft palate and when a previous straight line repair was performed. Among all the operations of velopharyngeal dysfunction, they cause the least amount of airway morbidity. The posterior pharyngeal flap is probably the oldest surgical technique described for management of the velopharyngeal dysfunction. It is a myomucosal flap elevated from the superior constrictor, the pharynx, from the posterior pharyngeal wall. Although an inferiorly based design has been described, most surgeons nowadays would use superiorly based flaps. The flaps are myomucosal flaps. They are elevated at the level of the prevertebral fascia. The idea behind them is they create sort of consistent obturator in the velopharyngeal area, and then leaving lateral velopharyngeal ports on both sides. There are many designs for insetting. Some would split actually the palate longitudinally. This is one other iteration of the operation where you create like a fish mouse incision in the soft palate, and then the flap is inset. The problem with the posterior pharyngeal flap is the significant morbidity to the airway. You would have consistent airway obstruction following this procedure, to the extent that you would have to maintain the patient post-operatively on pulse ox assessment, at least in an overnight stay, to assess for sleep apnea. Obstructive sleep apnea is a common complication in these kids. Sinusitis and infection because of the obstruction that you have created is also another issue. And some of these kids, if they don't tolerate the sleep apnea and the sinusitis, you would have to take these flaps down. The other operation is the sphincter pharyngoplasty. This is also a myomucosal flap that is harvested from the posterior pillars of the tonsils, that is the palatopharyngeus muscle. So the idea is to elevate the palatopharyngeus muscle on both sides and then create a transverse incision at the level of the soft palate high enough, and then inset these flaps in this incision. The idea behind it is that muscles would function eventually, and it would be a dynamic sphincter. But actually, functionality of this happens only in a subset of patients. Not all patients would acquire functionality of this type of reconstruction. And the main value of it is the reduction in the cross-sectional area of the pharynx that you create, and the posterior wall augmentation that you do by putting these flaps into the posterior pharynx. Again, airway obstruction, obstructive sleep apnea, and sinusitis is a real complication following these types of procedures, especially if the final port left is of limited dimension, and especially that scarring sometimes can set in and reduce the port size further. Augmentation of the posterior pharyngeal wall has been described. Many materials, whether alloplastic or autogenous, have been utilized, but really, to date, there is no none of the alloplastic materials has proved safe, effective, and with consistent results over time. With autogenous material, it's also unlikely to have consistent results long term. So these should be really reserved for a very select group of patients when you have adequate velar function and a very small port size to begin with. In intractable cases or patients who have failed velopharyngeal surgery, when you are out of surgical options, prosthesis can be helpful. These are palatal lift prosthesis that the patient can wear and lifts the soft palate towards the posterior pharyngeal wall, and can be supplemented with a speech bulb that fills in the defect and allows the velum and pharyngeal walls to close over this bulb and achieve some form of velopharyngeal closure. So mostly what we have done so far in Cairo University, we have not done many velopharyngeal patients so far, but in many of the patients, we would try a Furlow double opposing Z-plasty as a first maneuver, especially that most of these patients presenting to us have done a previous straight line repair. And this is one of these patients presenting to us. You can see a bifid uvula, short velum, and moderate velopharyngeal dysfunction. The flaps are elevated. And you can see that the black arrow points to the muscle tissue in the nasal layer, and the other arrow now points to the muscle tissue in the oral layer. And by double pressing this muscle, you can reconstruct the levator mechanism in close proximity to the posterior pharyngeal wall using this technique. This is just a video showing this operation. So you start by marking. The first Z starts from the hamulus towards the soft hard palate junction. The other is from the base of the uvula towards the other hamulus. This is after infiltration and starting elevation of the oral flaps. So this flap will be a myomucosal flap. So if you are a right-handed surgeon, this flap will contain the muscle. It's sometimes tricky in these cases because of fibrosis of previous surgery. This is the oral flap on the other side, on the right surgeon's hand right side. This will be only a mucosal flap. Relaxing incisions, I use relaxing incisions routinely. In this technique I use, it is very important to identify and skeletonize the greater palatine vessels to obtain free motion of the soft palate and tensionless closure, and allow the soft palate really to move backwards as far as possible. So this is the nasal flaps from the on the left side, from the base of the uvula towards the Eustachian tube or towards the hamulus. On the other side, you would have to free the muscles first from the shelf of the palate before you actually cut the Z. And this is the muscle after repair. This is the closure. And you can get an idea about the length obtained by comparing it to the pre-op picture. So this is just a pre and post-op picture to show you the amount of length that you can achieve with the Furlow double opposing Z-plasty. And this is a short video showing you first that you can obtain like almost 2 centimeters of palatal length, extra palatal length compared to the pre-op measurements. And you can clearly see that the uvula is touching the posterior pharyngeal wall. Thank you.
Thank you, Dr. Ahmed, for your presentation. I have had a few polls while you're presenting your talk. I'd like your feedback on that, Dr. Mamdouh, Dr. Robertman, Dr. Dawlat. Well, this is one of them, the preferred assessment method for surgical planning. You've mentioned, Dr. Ahmed, that you use the perceptual speech evaluation for assessment of the condition to begin with, but do you use that only, or do you as well go for the nasoendoscopy to decide on surgery?
It's a team. So you have to work very closely with the speech pathologist. Most of the time you would agree with the perceptual speech evaluation that he performed, and then both of you would actually attend or be in seeing the nasoendoscopy, and it's a collaborative decision.
Dr. Robertman?
I think this was just a wonderful presentation. I think it underscores to me what I saw last week, which was University of Cairo is really quite far ahead of the curve that I see around the world in general. I mean, most places I go, everybody's still doing a straight line closure, and when you're doing Z-plasties, you're a step beyond that because you're using local rearrangement tissues to great success, and it is fits very nicely in what I think my concept is, which is an anatomic cleft restoration. And so when I see a child that has VPD, I think of how did I inadequately reconstruct that palate, and I'm usually tissue deficient. And so if I've done a previous Z-plasty, then by adding the buccal flaps to lengthen the palate, it fits within the concept, and I don't have to use the pharyngeal flaps or sphincteroplasties. But using a Z-plasty as the first step makes perfect sense if you have a straight line closure. Sometimes I won't do that just if there's a little more scarring, and I think opening the Z-plasty might contribute more to that in the muscle. But other times, if you've got especially muscles that just look like they're short, a Z-plasty is wonderful, and it was presented beautifully. So that's really my only comment. I do think one of the things that is very rarely talked about is when you have the mid-face distortion already showing. So you're getting mid-face protrusion, your palate is back, and what happens to those children when you ultimately have to do the jaw surgery. And we know that when we have movement forward, a lot of those kids will become incompetent at the teenage years, and now you're stuck with another situation. So once again, I think with an anatomic restoration from the beginning, so you don't really have as much mid-face protrusion, you're able to do, like Ahmed said, you don't want tonsils there if you're going to have something that's going to change, and certainly the same is true if you're going to be doing jaw surgery later on. So I think that's something that we don't talk about enough, is our speech results should be based on a child that has a normal facial balance. Wonderful. Thank you very much.
Thank you, Dr. Robertman. I have a question for you as well. So what I understand that you go for the Furlow repair, and you use the vaccinator flap in the first surgery, or in the single surgery at the beginning. You do that, right?
Yes, I do that in the larger clefts. If I have a VO1 or small VO2, I will do a Z-plasty, just as was described last week so beautifully. But if I have a larger cleft, then I don't routinely use relaxing incisions anymore. Whether that impacts on facial growth, I think, is one small factor, but it does affect some lateral. We do know that. And so yes, I add them mostly primarily, and if they're already used, I can shift them back and I can rearrange them again because there's a lot more tissue to maneuver. So my repalatoplasty is essentially shifting a buccal flap that's already been used because maybe I need more length, and so I take it out of the maxilla and I transfer it back, and I can certainly show that sometime if you guys would like to see that.
Yes,
does that answer your question?
Yeah, maybe I didn't finish the question yet. So if you find your patient later on with the VPI, and you've done already your Z-plasty and you've done your vaccinators and you've obliged them, which technique would you prefer? Would you be comfortable with more, or is it according to the nasal endoscopy and your investigation findings?
Yeah, well, certainly Ahmed described beautifully the workup, and if my workup looks, and I'm still not getting a good reach, but I have a good functioning speech engine, the velar muscles are still moving, then I am, as I was describing, the first thing I'll do is shift my buccal flaps around. I may be able to do a repalatoplasty with the 6 flaps and create more length. That would be my first thing to do. Yes. And that's been quite successful for me. So I haven't really gone to,
yes.
I do what I call a functional palatal suspension, because when you lengthen the palate, it doesn't go like this, it goes down the throat. So the point of contact sometimes needs to be lifted. And then I do, I use a pharyngeal flap, but it's not done in a classic form of creating a port. I'm basically tethering the buccal flaps forward and upward to replace the musculus uvula muscle. and bring it up into position. That's another discussion. I can show you how that's done very easily. And that has made the 15% of kids that don't succeed with a palatal lengthening getting normal speech without changing the speech engine and without reducing the opening of the nasopharyngeal space. So no sleep apnea with that approach.
Yes, okay, thank you so much. Dr. Mamdouh, Dr. Mamdouh Al-Hassan.
Yes.
Could you give us your feedback on that, on patients with VPI? Which method are you comfortable with more, your techniques?
Yeah, I think the VPI is a very complex problem to address, and there are several views about them. My primary goal is always to use the functioning palatal muscles, because what do I believe, that the problem is always in the palate. It's not a problem of the pharynx, actually, or the pharyngeal. As I've learned from Dr. Robert Mann, using the buccinator flap first, in addition to a Furlow Z-plasty, would lengthen a lot. I did a lot of pharyngeal flaps in the past, but I think this is not a very good choice. Usually, people write a lot about how to do it, how to use it, but no long-term follow-up of the pharyngeal flaps is written in the literature, actually. And many of the adult surgeon, plastic surgeon, would show results of the flap getting very thin, and sometimes they have to cut it to the outside of the maxilla in full-grown children. So I usually leave that as a very last and very remote choice. Now, I don't like to do surgery. I concentrate mainly on palatal muscles, rearranging it in the its original orientation, and adding the buccinator, which acts as a soft tissue attachment to the hard palate, leaving the palatal muscles to act in harmony in the back of the palate. This is the main approach that I use.
Great, thank you, Dr. Mamdouh. So, Daulat, what's your take on that, on VPI, and which method would you consider favorable?
Hi, Ahmed. I think we all know that we are shifting to Furlow palatoplasty now in the primary cases. So I think it reduces a lot the patients with VPI nowadays. But if we have a case of VPI, I think we try again to do Furlow palatoplasty, and according the investigations and the speech therapy and all this diagnosis we have, we do the operation we need. But we start first with Furlow palatoplasty again. Then we can shift to a pharyngeal flap or sphincter pharyngoplasty according to the case.
Great, thank you for the input. So the poll shows us that 50% of the attendees go for pharyngeal flaps versus 20% with velum re-elongation or management. So maybe one of our attendees, or some of our attendees, think differently. Dr. Helmi Shalabi, would you like to give us your opinion on that?
Assalamu alaikum.
Wa alaikum salam.
Alaikum salam.
Thank you very much, Dr. Ahmed.
Welcome, Dr.
You have Ahmed Hashim. I think
Thank you very much.
Presented very good talk, and I
thank you, sir.
Thank you for your demonstration of the anatomy of the muscles of the palate, and stressing the importance of the levator muscle in the closure of the VPI. Second point, the diagnosis of the velopharyngeal dysfunction depends mainly in the clinical situation on the clinical evaluation by the cleft palate team. The cleft palate team includes the surgeon, the speech therapist, the audiologist, and others. They evaluate the speech. And the investigation in the clinical situation is the nasondoscopy. And the nasondoscopy, you can make images for the movement of the palate. The video fluoroscopy and the nasometry, these are investigations for academic research, for research only, and are not investigations to be routinely used in the clinical situations. The treatment now, I do more than 60% redo Furlow pharyngoplasty, Furlow Z-plasty. In most cases done, especially they are coming from some colleagues doing the straight line or the pushback or the others. And these are repaired very good by the Furlow Z-plasty and rearrangement of the muscle. So, and you can add the vaccinator if you need. The pharyngeal flap, I use it very few cases in very tough and fibrosed palate, and you can't do something, so you resort to the static technique like the pharyngeal flap. The sphincter pharyngoplasty is, as Ahmed actually said, it is a sort of posterior pharyngeal wall augmentation. It is not a dynamic operation, in my opinion. And thank you again, and thank you to Qasr Al-Aini for this very good presentation. Thank you.
Thank you, sir. Happy to have you. So a question from Montazir. I think you have it answered by now. Do you do Furlow's repair as a primary procedure for short palates as a primary method? I think all our professors and everyone has answered this question. I think everyone now is shifting to the Furlow's double opposing Z-plasty as a lengthening method. Another question from Eric Wongo. Now I've just started this poll, maybe a bit late with it, but we just started it. So he was wondering regarding the age of assessment for VPI, and when would you operate on it, on the patient. Our poll now giving us 46% with 23 attendees, considering as 2 to 4 years. Dr. Ahmed Hashim, what do you think?
So I want to highlight a couple of points here. First, I want to say about the Furlow and the two-flap procedure. And I mentioned this last time. There has been a systematic meta-analysis published in 2014. I think it's 2014 by the Cleveland Clinic Group. And this systematic meta-analysis analyzed previous studies where a two-flap procedure was done as a primary procedure for palate repair versus the Furlow double opposing Z-plasty as a primary palate repair. And this study showed that the need to do velopharyngeal surgery is less with the Furlow double opposing Z-plasty. Now, having said that, this study, there have been many comments, if you take a look at the literature about this study, of including, not including other studies of excellent outcomes and so forth. But what made this study very credible for me is that I personally knew the senior author of that study, and he was actually doing a two-flap palatoplasty. And upon the outcomes of his study, he was trying to learn the Furlow double opposing Z-plasty. So this is one point. The other point is I would agree with Dr. Professor Mamdouh and Professor Dr. Mann about really if you have still a short palate and you have previously done a Furlow, then the vaccinator makes absolutely sense in augmenting and getting more length of your soft palate and avoiding the dilemma of having an obturator placed back there in the posterior pharyngeal area. I have seen cases during my training, miserable patients suffering from obstructive sleep apnea, sinusitis, yes, they have an improved speech, but they are miserable because of this. And sometimes they can't tolerate these complications, and you have to take the flap down. So I think it makes totally sense to move towards vaccinator flap to lengthen the palate in these cases. So as regards the timing of assessment, so the team, the cleft team should see these patients after the cleft palate repair every year, and we would anticipate that the patients would start early speech by 1 year of age. So assessment would be like 2 years, 3 years, but really for these patients to be cooperative to do an nasoendoscopy for planning of surgery, this wouldn't be like before 5 years of age. But for the perceptual assessment, I mean, it's an ongoing process. Each visit, the child comes in, the whole team sees the patient, the speech pathologist, the surgeon. They talk with the parents. They understand how speech is doing. Speech samples are asked for the patient. So it's an ongoing process. But really, the critical factor that if you are embarking on velopharyngeal surgery, then you need a nasoendoscopy and you need a cooperative child. And I think not before 4 years to have a child cooperate and accept the nasoendoscopy.
Okay, thank you, Dr. Ahmed. Dr. Yusuf Saleh, حضرتك معنا.
Thank you, Professor Ahmed. First of all, I would thank my Professor Khalid Makin for this very nice presentation and very nice topic. And I would thank also my dear colleague, Professor Ahmed, and Professor Ahmed Safwat, and Fawlat, and our Professor Hassan for nice presentation. But I have a comment. As you know, in Asyut, we have a big center for the child hospital, and also inside this center, we have a center for the cleft. This center for the cleft is special for the examination of the child, including all the dilemma that Dr. Ahmed called it. First of all, I am agree Professor Paul. I am disagree with our professor for the simple reason. The only man who determine the type of operation and interference for PI is the speech progestin surgery, because there is several reasons, including the type of gap and the size of the gap. Type and size of the gap, this will determine your technique. So Furlow is suitable for all type of gap and size of the gap. Paul is doing a physiological flap or sphincteroplasty for more cases because he is dependent upon the movement of the flat or the gap size and type. The first of all, you should instruct the circle. In Asyut, we instruct the circle by doing several researches with our colleague in speech pathologist and otologist to make the team and the staff. And then when we make this circle, we will solve upon the team, and then we solve upon our program or our protocol for these cases. I would like to present that VPI is from 5 to 15% after good hand palatoplasty. If you are very good hand, you make 20 from 15 to 25% VPI patient. Number one. Number two, VPI mostly regarding to the speech pathologist, this will solve the most of their problem, and about 30% only that will interfere by surgery. So there is no rule about the Furlow. It's the only operation. This is I think that's big faults. You must assess the gap and type of the gap and the size of the gap, the mobility of the muscle. First of all, thanks, Dr. Ahmed.
Thank you, Dr. Yusuf. Dr. Robertman, would you like to comment?
Yeah, just another comment on the Z-plasty. I remember last week it was commented that the Z-plasty had been taught in the Cleveland Clinic, and I just would like to let you know that in the Cleveland Clinic now, the spectrum that we're talking about as far as creating anatomy, and the Furlow makes the anatomy more normal. In the larger clefts now in Cleveland Clinic, Frank Pepe and his team have incorporated buccal flaps now for quite a while. So I'm not sure when that training was, but it is something like Ahmed commented on. Primarily, you can add it, and secondarily. And also a comment, Joe Losi, who many of you know has been a huge advocate for Z-plasties can close every cleft. And of course, I did that too. I closed Z-plasties with every cleft. But now he's adding buccal flaps so that he doesn't have to have as much tightness and doesn't have to use the fat flap as often and things like that. So just a comment on that. So as you all are keeping open minds as you move forward and evaluating your children, thinking of the buccal flap as adding that extra anatomic tissue like the tensor veli palatini aponeurosis that's missing. That's just how my mind works now. When I see it, I look at what's the defect, whether it's primary or secondary, and how do I reconstruct it to normal. So thank you for that comment. Man, once again, what a wonderful lecture. I learned, I took notes. I don't know if you could see, I was taking notes while you were watching. So I'm learning every day. Thank you so much.
Thank you. So I just want to comment. I worked with Dr. Pepe. He's a great guy. He's one of my best mentors. I was very lucky to work with him as a craniofacial fellow. And that was the year when we did where they did the second face transplant, and I was very lucky to be part of it. But when I was doing my craniofacial fellowship at the clinic, Dr. Pepe was using a two-flap palatoplasty. Actually, my mentor who was doing the research on the systematic meta-analysis was Dr. Dumit, Gabi Dumit.
Yeah, up in Montreal now, yeah.
Yes, exactly. And he moved to Canada later on. But I learned the Furlow from Dr. Kirshner because I spent a pediatric plastic surgery fellowship with Dr. Kirshner before moving to the clinic. That's where I learned the Furlow with the chop modifications. So that my training is a little bit variable because I've seen, and I trained with Dr. Murty and Ann Murty in Akron as well. So I have seen both techniques. I've seen the two flap and the Furlow palatoplasty. And for me, it was obvious for me, the choice for me was obvious. I couldn't resist the charm and the elegance of Dr. Kirshner.
Yes, no, he does a beautiful Z-plasty without question. And but you're going to keep your open mind. Frank Pepe and Gabby both had been up to Grand Rapids, and subsequently they don't use it all the time, and I don't either. I use it about 30% of the time. But as you find with your wider clefts and you're looking at your results and you're saying, wow, I'm doing so great on these 1s and small 2s, the big Pierrot bands also are tissue deficit, but you're going to incorporate that. I think it's just going to naturally happen for you.
Yes, thank you.
Thank you.
Thank you, Dr. Ahmed. Dr. Wael Saar, I'm very happy to have you with us tonight in our meeting. Actually, I have a couple of questions for you. The first one, which method you consider for primary cleft palate management, method of surgery? And when would you typically consider management of a VPD or a VPI patient? When you consider proper age to tackle this problem?
Thank you, Ahmed, for having me with you. First, I have to congratulate Ahmed Hashim, my dear friend.
Thank you.
As he's always Ahmed is always illustrative. I know he's proposing the operation, the whole subject, especially for the juniors. We all know, as my friend Yusuf said, it's not a minor thing. Approximately, we may reach 30% of the patients, maybe from 15 to 30, as Yusuf said, have VPI or something like this. So if we are allowed to make the palatal repair as early as possible, it would be very nice. Maybe I was accustomed to do the posterior pharyngeal flap posteriorly before knowing the new investigations and the multi-modality treatment or multidisciplinary teams. I think now, as Ahmed mentioned, whatever, if we have the availability to have video nasopharyngeal endoscopy, nasometry, pressure flow, MRI imaging, all these, and the speech therapy, all these would improve our results. That's why it's a very important message to the juniors. We have to do, if we do have many options, surgical options like palatal repair with repositioning of levator Velopharyngeal palatini muscles, posterior pharyngeal flap, sphincter pharyngoplasty, all these should be assessed also by the new tools of management. That's why it's very important to know that it is not a one-man show. It's a very good, Ahmed, what you did present. I think when I'm doing just only as I was doing myself before, just posterior pharyngeal flap, why the patient did not improve? That's why I didn't have the tools. What do you think, Ahmed?
Yes, I totally agree. Absolutely. It's a team approach. You have to listen to your speech pathologist. You have to be collaborating with him, and really to analyze the problem, to analyze the issue. Is it a true anatomic defect? Where is exactly the defect? And what you need to do in order to correct it and achieve optimum outcome with least airway morbidity.
Yes, I forgot to say from the start, is it an anatomical defect also, or a dynamic defect? That's why maybe the difference in understanding the true pathology.
Yes, sometimes in some cleft populations, especially those with the 22q deletion syndrome, the velocardiofacial syndrome, they are notorious because they have a very deep pharynx, and they have, in addition to the anatomic defect, they have neuromuscular hypotonia.
Yes.
Which is you can do a very good muscle repair, reconstruction of the sling, and still not obtain good function because of the neuromuscular
That's what
hypotonia.
I mean. Yes.
Yes.
You did a good operation, and you don't know what
exactly.
where is the
yes. So proper analysis is critical. Yes.
Thank you, Safwat, for inviting me.
Thank you, Dr. Wael. Dr. Dawla, do you have a question?
Yes, Ahmed, I want to ask Dr. Robert Mann about repairing patients with VPI if they are coming late age, like adults or something. So what are the main benefit of repairing these patients in this age?
I think you can improve patients at older ages. If you have compensatory issues, they're going to have to do some biofeedback training to correct that. It's not common, but I've had in the last few years, I had a 26-year-old who was a social worker, and she just was not understood well enough, and we were able to do VPD surgery and recover her to the point where she was able to be functional on the phone and a lot of other things. So I don't have an age anymore. I look at it anatomically, find out what I need to reconstruct it. If the muscles are paralyzed, if you have a cancer or you have something like that, that's a totally different issue. And then we're stuck with compensatory surgeries like sphincteroplasties and pharyngeal flaps. But I don't have an age. It used to be when we were taught after a certain age, why bother? They're not going to change their speech. But I think with good biofeedback training, they can do that. And certainly, even without it, I've done kids 15, 16, 17, and you fix theirs and just get them regular speech therapy, most of them will recover. But if they have a pharyngeal flap and they're trying to work with this abnormal compensatory operation, like Brian Summerlad says, the quick muscles of the velum are entirely different than the swallowing muscles of a pharyngeal flap closure from the lateral walls. And I think that puts them at risk for not making a good change.
Can I comment on that, please?
Oh, yes, please, Dr.
Yeah, I agree with you, Dr. Mann, that it can be corrected at any age if you have movable muscles. If the muscles is still working, and this you can detect it by the nasoendoscopy, there is a chance that the patient would improve. Two things that you have to tell the patient, that it's not only the surgery, it's also the speech therapy after the surgery. And many patients will improve. I used to be reluctant to do such patients, but when I started doing them, and we did the thesis in Mansoura University 2 years ago, and we did about 15 patients above the age of 9 and 8 years, 8 and 9 years old, and they improved a lot. And also I did patients in the teenagers in the 17s and 18s, and they did well. So I would encourage everybody, if you have a good acting muscle by the nasal endoscopy, he would hop on and do the surgery.
Okay, thank you, Dr. Robert, and thank you, Dr. Mamdouh, for this comment.
We have a question from the audience. Dr. Ahmed Al-Sherbini, you have a question, please address it. Go ahead.
Assalamu alaikum. Psych University. Regarding the protocol, which Dr. Ahmed, thank you for the lecture. The protocol which sagittal and coronal closure, which is depending on the lateral pharyngeal wall. Actually, this is a very old protocol, mostly popularized in USA since long time. But if we go to the other side, if we go to Europe, especially UK, we will find a protocol based mainly in focusing to optimize the palatal form and function before doing any pharyngeal flaps. As also Dr. Ahmed said, that to do the palatoplasty. But there is other list of surgeries you can do it in these categories, the palatal procedures, like doing midline intravenous veroplasty, Z-plasty, Furlow, vaccinator intravenous veroplasty. We just published it in the cleft palate craniofacial journal. Also, fat injection to the palate, not to the pharyngeal wall. And when to choose between all these surgeries, there are many factors, but none of them is the lateral pharyngeal wall, because the lateral pharyngeal wall is actually a false sphincter. It's a lower level than the level of the closure of the levator and levator knee. Also, I want to talk about which one, like Z-plasty, the Furlow Z-plasty or intravenous veroplasty. We used the Summerlet type intravenous veroplasty. And actually, depending on the meta-analysis, it's not accurate to depend on the data of the meta-analysis, because not all Furlows are the same, and not all intravenous veroplasties are the same. But other way to assess it, like Summerlet has a 5% VPI rate. This is one of the best intravenous veroplasty. Also, I think Furlow has also, I think, 6%, 6.6, like Dr. Mann and Children's Hospital of Philadelphia have about around 6.5. So both procedures actually are very good, but it should be done well, because we see a lot of cases which we go to do secondary intravenous veroplasty after Furlow palatoplasty, and we find it's always asymmetric, because the flap which you raised posteriorly based, it's rarely they include the levator. They include the palatopharyngeus, but not the levator. So many cases we open, we find that the left side is the muscle is moved, but the right side is not moved at all. So I congratulate that you're doing it in a good way, but I am just telling you that many people are not doing the good Furlow. So I think both ways, if you do it very well and you master it, you can find like 5-6% of the Furlow. Also, and this is why we depend on the lateral venifluoroscopy more, because we want to see where is the levator position rather than the lateral pharyngeal wall. And we published this protocol also. It's a nice paper in the cleft palate craniofacial a couple of months ago. You can check it, and you'll find when we select each of these procedures and then we only 15% of the cases will need the pharyngoplasty procedure. And also, it's not a pharyngoplasty which is depending on the lateral on the posterior pillar, because this will make a lower level of pharyngoplasty. It's more higher just in front of the levator knee. So you have to open the palate to reach up high to complete the real actual level of the pharyngeal valve. And thank you.
Thank you, Dr. Sherbini. Dr. Ahmed, would you like to comment on that regarding the Furlow procedure?
Yes, thank you for your comment. So a couple of comments. So obviously, one of the issues with the Furlow palatoplasty is really you need to know how to do it. And I think this is the critical factor that deters many surgeons from doing the surgery. And as you mentioned, many of them, it's not like a technique that you can read it and just do it. You have to get in-depth training for a period of time with someone who is really mastering this technique in order to be able to do it safely in every cleft patient. So that's for the furlough. The other thing, as regards the assessment, so there are many modalities of assessment. I think the nasoendoscopy in most centers worldwide is accepted as a very important tool that allows you to see the defect and see the actual dynamic function of the velopharyngeal mechanism in real time. The other issue of putting the pharyngeal flap or putting the sphincter pharyngoplasty, exactly the level at which you put it is actually a technical issue that you can modify and alter. If you have the proper training, you can always put your pharyngeal flap or your pharyngoplasty at the level that you like if you are have a good planning from the outset. So, but I mean, congratulations for your work. Thank you.
Thank you,
Thank
Dr. Ahmed. We have our last question from Dr. Ahmed Ibrahim.
Good evening for all my colleagues, and thanks for you, Dr. Ahmed Safar, for your effort in coordination of meeting, and thanks Dr. Ahmed Hashim for your nice illustrative presentation. I just want in brief talk about we should start repair of soft palate primary repair by straight line repair or by Furlow repair. I will look at this point on another view, depending on the base of reconstruction, which called we should have a reservoir. So we should start by straight line repair of soft palate, whatever with any technique of with lateral release of flap elevation, and keep the Furlow if the patient come later on with VPI. Now we have a reservoir and we can do the Furlow in the second stage. But if we did Furlow at the start and the patient come again for VPI, so it is obligated to go to the buccal flap or the pharyngeal or whatever with pharyngeal flap or pharyngoplasty. Second, so what's your opinion about this matter? Second, the question about what about fracture of hamulus during repair of cleft, soft cleft palate? As you know, the most important muscle is the levator villi, the levator villi, not the tensor villi. So after fracture of the pterygoid hamulus, we can decrease the tension on the levator and close the soft palate. It's in a straight line without any tension. So what's your experience about fracture of the hamulus or even removal of it in cleft lip repair? Thanks again.
Thank you, Dr. Ahmed. You meant regarding cleft palate management or repair. So, Dr. Ahmed Hashim, would you start with you? Would you consider this procedure?
Yeah, first, thank you for your comments. For the first comment, as I mentioned, so this operation, the primary palatoplasty, is an extremely important and critical milestone in the life of this patient. And I think you should give your patient the best chance at this primary repair. The goal should be to have the best palatoplasty procedure performed at that time in order not to come back. Remember that every time you open the palate, you incite more scarring, you inhibit the growth, you inevitably, every time you take sutures again and open up again, you incite more scarring, and this will decrease muscle function. So that's my philosophy when I approach these patients, and I always tell the residents that this is the most important operation for this child, the primary palatoplasty. It should be done very well, because as mentioned, this will determine his social and his career future. So it's absolutely important to have the best possible procedure done at the primary repair. The second question about the fracture of the hamulus, this is an interesting question. I don't fracture the hamulus. I don't need to. Releasing the muscles, doing a proper release and proper dissection of the flaps, and skeletonizing the greater palatine vessels would give you absolutely no tension. The whole idea about the Furlow palatoplasty, the way I was taught to do it, which is the chop modification, is really to medialize the tissues and have no tension in the midline. This comes at the expense of relaxing incisions. So having said that, the original Furlow description is, and in his talks, Furlow discourages against doing relaxing incisions. And one time he was talking in the pediatric plastic surgery meeting, and Dr. Losey asked him, so how do you close some of the wide cleft patients? And he said, I would do a back cut. I would do a back cut in the Z-plasty. And Dr. Losey told him, okay, so this is the same. We're talking about the same thing. You're just mentioning, you're just stating that it is a back cut, but we say it's a relaxing incision. It's the same concept. So really fracturing the hamulus is not necessary if you learn how to do this operation properly. The other thing that this point reminds me of is the paper by Cutting. Cutting did, because you mentioned the tensor veli palatini muscle, which is an important muscle in the function of the Eustachian tube. And many of these patients will have Eustachian tube dysfunction, a significant proportion of them. And Cutting actually proposed what he called tensor tenupexy. So at the outset and before incising the palatal aponeurosis, you would go on and do a ligature of the tensor tendon around the hamulus to maintain the muscle tension of the tensor veli palatini muscle. And by that, he showed that those patients where he did the tenupexy required less ventilation tubes and had less middle ear issues. So that's my comment.
Thank you, Dr. Ahmed. Dr. Mamdouh Abul Hassan, will you consider this technique for fracturing the hamulus to provide further mobilization?
Yes, I used to do that 20 years ago, actually. But when I learned how to do the two-flap palatoplasty in the beginning of my training with Dr. Salier in Dallas, and he showed me how, as Ahmed said, how to dissect or skeletonize the pedicle completely without doing any fracture or any cutting of the tendon. We used to do that in my early training, but I stopped doing that 20 years ago. And about 7 or 8 years ago, I stopped doing two-flap palatoplasty, although I had very good speech results. But the number of patients that had to do a secondary procedure, and I did a Furlow conversion for them, was good enough to turn me into doing the Furlow Z-plasty. One second thing, a comment about Ahmed of doing even a releasing incision. You can avoid that by using a buccinator. This is a point of debate between me and Ahmed, actually, of having to do a release incision while doing the Furlow. Furlow himself, as you said, didn't do that. And I talked to him personally, actually, in one of the ACPA meeting, and he said, you always don't have to pull the angles to the other side. You usually have a defect either on the oral or on the nasal side, which is covered by the muscles, so no problem of leaving a raw area or deficient one or two sutures at the angle on the oral or on the nasal side. Actually, the buccinator have solved this a lot, and leave even the origin of the muscles completely intact without compromising the blood supply or even affecting the growth later, as I believe. I can hear the comment of Dr. Mann about that.
Yeah, I think you said it very well. The dissection that of the Z-plasty that Ahmed does beautifully, and he commented how you have to be an excellent surgeon to do that. I think is in my view, when I started adding the buccinator, actually simplified the operation because I don't skeletonize the artery, and I don't have as much release laterally, and the muscles. I think the muscle dissection is actually easier as well. I used to do hamulus division, but that was 30 plus years ago, and I haven't done that in probably 25 years. So I agree completely with Ahmed. You can do a very nice dissection without having to release the fracture the hamulus, and the hamulus is also a spectrum. Sometimes the hamulus looks very normal, and other times it's just so hypoplastic you can hardly find it. So I hope that answers the question. I agree with Mamdouh, and I agree with Ahmed on both those pieces.
Thank you, sir. So we'll be ending our talk with the last comment of our professor, Dr. Helmi Shalabi.
I would stress on the point of fracture of the hamulus. Please don't fracture the hamulus. I adopted the double opposing Z-plasty since 1993. Before that, I was doing the lateral releasing incisions like von Langenbeck and the pushback operations and so on. And I reached to the fracture of the hamulus and even subperiosteal dissection of the blade, of the medial blade of the hamular plate. And these dissections, in my opinion, at that time, was to push even the lateral wall of the pharynx too, so I can close the palate easily. But I found it affecting the growth of the maxilla later on. And since I adopted the double opposing Z-plasty, I never fracture the hamulus. And another area that we were fracturing is the premaxilla. This is another area that was fractured to close bilateral, severe cases of bilateral cleft palate, and the fracture of the premaxilla was deleterious on the growth of the maxilla. And I say no fracture to the premaxilla or the hamulus. Thank you.
Thank you, Dr. Helmi. I think we've come to the end of our meeting. I'm really happy to have had this talk. Dr. Ahmed Hashim, always a pleasure to have your talk and have you with us.
Thank you.
Of course, our professor, Dr. Khalid Makin, Dr. Robert Mann, Dr. Mamdouh Al Hassan, our co-hosts, Dr. Daulat, Dr. Haitham, everyone from the attendees today and tonight, and hopefully see you next Sunday, same time with a new topic. See you then. Thank you all.
Thank you.
Thank you.